Okay, that worked. I don't know why it does that, but anyway. All right, so we have just two things to get through today. We've got chapter 6 and chapter 7. We're just about done with all of our OB stuff. So after today, I think we have two more chapters to go through in OB and we're completely done with OB. And then we start into PEDS. So, in this chapter, it just starts talking about antepartal tests. So, what this means is, when someone, this is before someone has a baby and you're maybe kind of worried about their pregnancy and for some reason, and you're trying to figure out, specifics about what's going on with this baby or this mother. So, again, the chapter just focuses on these tests mainly. Um, they're offered to pregnant women, focusing specifically on, um, at risk or high risk pregnancies. So that's kind of what we're getting into in this chapter. Okay, so this talks about a couple of different things that you're going to assess with a high risk pregnancy. So, things that you're going to look at would be biophysical factors like genetics, their nutrition, their medical history, and any kind of OB issues that they've had in the past. So, like, say they've had babies before and they had a issue, with a pregnancy before, then, yeah, that's something that's going to be significant. Psychosocial. So, we're looking at things like their smoking history. How much caffeine do they take in every day? Do they do any alcohol or drugs? And then what's their psychological status? Are they, some kind of psych history patient or something? And we're also going to look at socioeconomic factors. So we're going to, assess things like access to prenatal care, because there's a ton of people out there who don't even do any prenatal care, which is not good. You want to look at their age, their parity, their marital status, their income, and their ethnicity. And then the last thing we look at is environmental. So, hey, do they have any, exposure to chemicals or radiation or pollutants? Because that could affect, their pregnancy big time. Okay, so some of the things that we do during these tests, as a nurse. So we want to, explain to the woman how the test or procedure is performed. We want to explain any potential risks and benefits of having it. We want to tell the woman what to expect during the test or procedure so she's aware. We want to explain what the test measures, encourage her to ask questions during everything, and then foster open communication between the patient and the provider. And then, if they have further questions or something and they're trying to decide if they want to have one of these tests, then maybe you give them some kind of online resources for further information. So those are some of the things that we would teach. And then, of course, we're going to provide support. During some of these procedures, sometimes, it might be uncomfortable for the woman to lay a certain way. So we're going to try and make her as comfortable as we can. And then we're going to try to reassure this woman and significant other throughout this procedure. So if they are really uneasy and unsure about it, then you can have the significant other stay with them throughout the procedure. That's totally fine. Now, during these tests, if the physician or whoever is performing the test needs some assistance, then sure, we might be there to help do whatever they need. But our biggest concern during these tests is we're going to monitor the mother and the baby's response to the test. So we're going to document this, in our chart. And then if there's anything that's abnormal, we definitely want to report these, results to the provider. Another thing that we'll do is we'll help schedule appropriate follow-up. So, if there is something that you see that is abnormal and they need to be seen again, you're going to, facilitate scheduling that. And then you're also going to reinforce any kind of information given to the women by the provider regarding results of the test and need for further testing, treatment, or referral. Okay, so prenatal detection of abnormalities provides an opportunity for the patient and provider to prepare and intervene if that's the case. So there's a couple of different types of tests that we do. There's screening tests and diagnostic tests. So a screening test is they assess the risk that the fetus has specific common birth defects, but screening tests cannot tell whether the baby actually has a birth defect. So it might tell you that they're more at risk for it, or they think they might have it, but it's not like 100% sure. These type of tests typically carry no risk to the fetus if you get it done. So that's kind of nice. So for the woman, I think that would be comforting to know that. With diagnostic tests, these provide a definite yes or no answer to whether a fetus is normal or abnormal, and it can detect many but not all birth abnormalities caused by defects in a gene or a chromosome. Now the thing with these tests is some of these can carry some risks. So a couple of them even have a risk for pregnancy loss. Even though it's a really tiny little risk, it's still there. So it's kind of, more upsetting to people to think about. Diagnostic tests are available as the first choice for all pregnant women, including those who do not have risk factors. So it is, if they were concerned that maybe there was something wrong, it is, something that they could have done. So I'm going to give you a list of a couple of different screening tests. So if we were doing a screening test, the one that isn't 100% sure, some of those include amniotic fluid index, the biophysical profile, contraction stress tests, daily fetal movement count, multiple marker screening, alpha fetoprotein screening, non-stress test, nuchal translucency, and there's a couple others. I won't mention every one of them. And then for the diagnostic tests, I'm just going to give you a couple examples of those. So this would be amniocentesis, chronic villi sampling, magnetic resonance imaging, percutaneous umbilical blood sampling, and then, ultrasound. All right, so then on these further slides, this kind of gets into a little bit more detail about some of these tests. So biophysical assessment, we're going to talk about that first. So what they do is they do an ultrasound. This is used to obtain the following information. So we want to see, we want to see the presence of a gestational sac. We try to look at the gestational age, according to the ultrasound. We check the baby's growth. And then you're kind of able to see on the ultrasound sometimes if there's, a problem with fetal anatomy or how they're presenting, like if they're breech or something. You also are going to look at placental location. You're going to look at fetal activity. You're going to check the number of fetuses, the amount of amniotic fluid, And there's probably a couple other things, but that's most of what they do with the ultrasound. Now, for this ultrasound, they also sometimes will use it as visual assistance for doing certain invasive procedures like amniocentesis. And remember, we said amniocentesis is more of a diagnostic procedure, not a screening procedure. Okay, so they also talked about, in the chapter, it talked about MRI. So sometimes they'll have people go for an MRI if they're, maybe they did the ultrasound first and they see something they're not quite sure about and they want to get more detail. So they'll send them to that. And of course, you have to lay flat, which is sometimes hard for women because, all that extra weight, with the baby. So they say supine position, left lateral tilt. And then the abdominal area is scanned. And this is going to be useful when trying to get more detail about possible brain abnormalities. So if they really think that something's going on there, this is what they'll do. And then there is something called Doppler flow. This is going to assess the placental perfusion. And it's not a useful tool in determining fetal compromise. So basically, you're just trying to see that the fetus is getting a good blood flow with this. So all of these three things are part of the biophysical assessment. So ultrasound, MRI, Doppler flow. Now, there's different types of ultrasounds too, so I just wanted to mention that real quick before we move on. So there is a transvaginal ultrasound. So this would be used in the first trimester, and it's used so you can get an earlier visualization of the fetus. So they actually have a probe that they insert into the vagina, so you're like right there and you can see everything. And then you have your basic run-of-the-mill abdominal ultrasound that we're all used to. So for that one, you have to have the mother have a full bladder. This helps to move the uterus out of the pelvis for a better visualization. And then I'm sure you guys have seen, someone has had a 3D or 4D ultrasound before. Not every place has the ability to do that. Some places do. But with those, it's kind of nice because it's an advanced type of ultrasound that takes thousands of images at once to produce this image that just almost looks like a picture, like you're right there. So this can be used to determine fetal size, the amount of amniotic fluid, to determine complications like hydrocephaly and inflammatory disorders of the brain. So it is kind of useful for some of those things. Okay, which test best provides an answer to the question of whether or not the infant has a congenital defect? So remember, we talked about screening and diagnostic. So screening is not the best. Diagnostic would tell you a yes or no, right? So diagnostic would be our answer here. Okay, so let's move on here. All right, so this is talking about a couple other tests. So there's something called chronic villus sampling, or chorionic, I think is how you say it. So what this is it's an aspiration of a small amount of placental tissue. And what they do is they take that placental tissue and they're looking for chromosomal, metabolic, or DNA issues. That's what you're looking at. So the nice thing about this test is it can be done early. So like 10 to 12 weeks of pregnancy, you can have this done. And this is going to detect fetal abnormalities caused by genetic disorders. So this can be done a couple of different ways. So they can do it transvaginally, where they actually go through the cervix and get their sample that way, or they can actually go through the abdominal wall using a needle and aspirate the placental tissue from that. Typically, you get your results in about a week, which is nice because it's not too long. And then other advantages of this, like we said, it can be done super early, so that's great. And then also you can examine fetal chromosomes with this, and you can't do that with just every test. So that's kind of beneficial in that way. So there are some risks to this. Some of the risks would be bleeding, infection, and then rupture of membranes. So you don't always have to tell people, risks and benefits of any procedure before they decide to do it. I believe in the chapter when I was reading about this, an example of something they might be testing for this particular test would be cystic fibrosis. They might be able to tell if someone had it from that. All right, and then amniocentesis. I'm sure we've all heard of that before. So this is where they put a needle inserted through the maternal abdominal wall into the uterine cavity to obtain amniotic fluid. So remember, for that last one we just talked about, they're taking like an actual part of the placental tissue, and now this, they're just getting amniotic fluid. So this can be done for genetic testing, for assessment of fetal lung maturity, assessment of hemolytic disease, and there's like a huge long list of other things that they can actually use this for. The thing with this one, though, it can't be done as early as the chorionic villi sampling. So this one you can only do you have to be about 15-20 weeks gestation to do this. Now, they do this under ultrasound guidance because, again, they take a needle and they go through your abdominal cavity, so you have to make sure you're in the right place. So by using the ultrasound, they can kind of, figure that out. This, which I thought was cool, has an accuracy rate of 99%, so it's pretty darn accurate. Chromosomal studies are available in 2 weeks, so you don't get your results as quick as you would with the other one. Advantages, it examines the fetal chromosomes for genetic disorders. You can see a direct examination of a biochemical substance, so you're actually looking at that amniotic fluid to make sure everything's good there. Risks, trauma to the fetus, or placental bleeding or leaking of amniotic fluid, preterm labor, maternal infection, and then Rh sensitization from the fetal blood into the maternal circulation. So that could be another risk. So the only time that's really a concern is if, the fetus and the mother are different with their Rh status, So like say the mother's Rh negative and the fetus is Rh positive, that's when that would be an issue. Okay, and then the last thing on this slide talks about the PUBS tests. What this stands for is percutaneous umbilical blood sampling. It's a mouthful. Okay, so what they do is they remove fetal blood from the umbilical cord. And they can test this for metabolic or hematologic disorders. You can use some of this blood for therapies too. So it's like you can, do like a platelet transfusion through there. You can do red blood cell transfusion if you needed to. So it's kind of nice that way. Usually this is performed after the ultrasound detects an abnormality of the fetus. So you wouldn't just go ahead and do this test unless you were worried something was wrong. This is done about 18 weeks gestation to evaluate potential diagnoses and to make further recommendations for treatment. Again, this would be done with ultrasound guidance. A needle is inserted near the umbilical vein. And then risks for this would be cord vessel bleeding or hematoma, maternal fetal hemorrhage, fetal bradycardia, and then also risk for infection. Okay, so I'm trying to tell you like some of the risks and benefits for all of these tests as we go through. So some of these slides, I've already said some of this. But as far as our actions go for during this testing, and the diagnostic testing, remember, is a little bit more, you have more of a risk during that, even though it's something that's going to give you a decent answer about stuff, which you would think that would be good. It's still kind of risky and it's scary for people. So some of our actions that we do during these tests, we want to make sure the patient's in the correct position for the test, because certain things you need to be laying a certain way or whatever, so you need to make sure they're in the right position. Assess the fetal and maternal well-being pre, during, and post-test. The fetal heart rate is assessed twice in 30 minutes during this. And then, of course, you're going to provide emotional support to the family and everything during this, and provide comfort measures. And then we're also going to administer RhoGAM to Rh-negative women post-procedure to prevent antibody formation in Rh-negative women. So after this, that umbilical blood sampling thing is done, you're going to assess fetal well-being post-procedure for 1 to 2 hours. So you're going to actually have them hooked up to an external fetal monitor for that. All right, so then we start getting into maternal assays. So this is kind of like blood tests, I guess, if you want to put it that way. So maternal assays are an increasingly common way to screen pregnant women for fetal birth defects or genetic anomalies. Choice of screening tests depends on many factors, including timing of entry into prenatal care. So like if you haven't had any prenatal care and then all of a sudden you come, that kind of makes them make a decision about this. The goal is to offer screening tests with high detection rates and decrease false positive rates that provide patients with diagnostic options. So the first one they talk about on here is alpha-fetoprotein. So this is a glycoprotein that's produced in the fetal liver, GI tract, and yolk sac in early gestation. So they could do this test around 15 to 20 weeks gestation. So basically, if you had a high level of alpha-fetoprotein, this might mean that you have a neural tube defect with your baby. If you have a low level of alpha-fetoprotein, this is associated with trisomy 21 or Down syndrome. So obviously, if you have abnormal readings on any of this, you would do further testing to see, because this is just like a blood test, so you would want to get more, diagnostic testing to see what's what. So this also talks about false positives and false negatives. So a false positive just means that the test may detect as positive even though it's negative. So a false negative would be the opposite of that. It would mean the test might say that it's negative even though it's positive. So obviously we want to try and get tests that aren't going to be like that, that we're going to have less and less of those false readings and actually have a decent reading. The multiple marker screening. So this combines all 3 chemical markers. So the alpha-fetoprotein, human chorionic gonadotropin, and estriol levels. So with maternal age, they look at this to detect some trisomies and neural tube defects. This can be done within 15 to 16 weeks gestation. So some of the things you'd watch for with this test. If you had low levels of alpha-fetoprotein and unconjugated estriol levels, this is going to suggest an abnormality. And then with the human, I can't say it, chorionic gonadotropin, so that would be twice as high in pregnancies with trisomy 21. And then you would have decreased estriol levels if maybe this person had a neural tube defect. So those would be some of the things you'd be looking for there. Okay, so this starts getting into fetal movement counting. So this is basically your kick counts. So you want to see that this person has 10 distinct movements in 2 hours because that's normal. So if you had a mother doing these kick counts and they had fewer than 4 fetal movements in a 4-hour period, that should be reported. That's not good. Usually, if you have decreased movement, this indicates a potentially hypoxic fetus. All right, so then it starts getting into a little bit about the non-stress test. That's what NST is. So the non-stress test is the most common method of fetal surveillance. So the fetal heart rate is monitored with an external fetal heart rate transducer until it's reactive, up to 40 minutes. So in other words, you're looking at those, movements of the fetus on the fetal heart rate monitor. So the non-stress test has a high false positive rate, over 50%, but it has a low false negative rate. And the next one on here is the CST, that's the contraction stress test. What this is, it's a screening tool to assess the ability of the fetus to maintain a normal fetal heart rate in response to uterine contractions. All right, and then the next one, the AFI. This is the amniotic fluid index. So this is based on fetal urine production, believe it or not. This is predominant source of amniotic fluid, and it's directly dependent on renal perfusion. So if there is persistent decreased blood flow to the fetal kidneys, it results in a reduction of amniotic fluid production. So in conjunction with a non-stress test, it's an accurate way to detect fetal hypoxia. So the average measurement in pregnancy is 8 to 24 centimeters. So it would be abnormal if your amniotic fluid index was below 5. All right, and then the last thing here, it talks about the biophysical profile and modified biophysical profile. So basically they do an ultrasound assessment of the fetus along with a non-stress test. And you're looking at basically 5 things. So you're looking at fetal reactivity, fetal movement, tone, breathing, and amniotic fluid volume. So by looking at those 5 areas, you give a score to each of those if they're present. So if it's present, you would give it a score of 2. If it's not present, you would give it a score of 0. So if you have a score of 8 out of 10 or higher, that's good. That's reassuring. If your score was 6 out of 10, it may mean that you need to repeat testing, pretty soon, like in 12 to 24 hours. A 4 out of 10 warrants further evaluation and consideration of delivery. And a 2 out of 10 prompts immediate delivery. So that's saying there's a huge problem. So I thought it was kind of interesting. In the book, it was saying fetal activity will decrease or take steps to reduce energy and oxygen consumption as it gets more and more fetal hypoxia. So fetal activities that appear earliest in pregnancy are usually the last to cease. So those would be tone and movement. So like out of those 5 things, it would get rid of certain areas. It would just shut that down, to help, with the hypoxia. And the last 2 things to shut down would be tone and movement. All right, so we kind of talked about a ton of these tests already. So with fetal surveillance, so what when it says what tests are included, we've talked about all of that. So basically, what's the goal of these tests? So what we are trying to do is we're trying to identify problems early so that we can come up with a plan of care and a way to treat people if we can. If there's something that is treatable, we try to treat it before the baby even comes out. And, hopefully that will give them a better outcome. So that's kind of what we're going for. All right, so as a nurse, if you worked in OB, you need to have a certain level of skill and knowledge to help interpret these test results, to know, with that biophysical profile, what we were just talking about, know what those scores mean, know when you're supposed to, call someone or say something, about that. And then, talk about these different tests with your patient and tell them what to expect and all of that so they know what to expect, and give them support because it's very nerve-wracking for a lot of them. Okay, the multiple marker screenings identify what? This is going to identify neural tube defects, A. All right, so the biggest thing that you need to get out of this chapter is, there's different types of tests that we do when we're concerned about a pregnancy, whether it's high risk or whatever. There's screening and diagnostic procedures. The screening is not going to have as much of a risk to the baby or anything. So, maybe people might be more willing to do a screening type of a test, but the diagnostic test is going to give you a better yes or no that there is a problem. And some of those come with a lot of risks. So we need to, make sure we have a little bit of knowledge about all of these tests so that we can better, treat our patients throughout their pregnancy. All right, so that's that chapter. All right, so the next one is chapter 7. Let's see if I can get to that real quick. All right, so this chapter kind of has a lot of important stuff in it. So if anything, I would try and focus a little bit more on this chapter because it talks about some of those, complications that you might see during pregnancy. So in chapter 7, you're basically looking at high-risk pregnancies, right? So let me get to the right slide here. All right, so the nature of a perinatal nursing is unpredictable, and pregnancy complications can arise abruptly, resulting in rapid deterioration of the mother and the fetus. So it's important that nurses understand the underlying physiological mechanisms of pregnancy, the impact of the complications on maternal and fetal well-being, and current interventions to optimize maternal and fetal outcomes. So that's kind of what we're getting at in this chapter. There's quite a few different things that we're going to talk about. Okay, so how do we identify who is at high risk, in their pregnancy. So the goal of risk assessment is to identify pregnant women at risk for developing complications and promote risk-appropriate care that will enhance maternal and fetal outcomes. Risk assessment tools have poor predictive value, but they can help identify between women who are at high risk and women who are at low risk for complications. So in the book, there's this, I think there's a box up at the top of the one page, and it says, what makes a pregnancy high risk? So some of the things that you would be more concerned about in a woman if they were pregnant would be someone who is pregnant when they already have an existing health condition. So like if I already have hypertension or I have diabetes or something like that already, that's going to complicate my pregnancy even more. So they would be at high risk. A history of prior pregnancy complications. So if before when I had a baby, I had, preterm labor or, I don't know, gestational diabetes or something, I'm more at risk again because I've had it before. Complications that arise during pregnancy. So, if they're going along just fine at first and then all of a sudden they start to have a complication, then they're a high risk. So like maybe they get preeclampsia or something. That would make them high risk. Being overweight or obese is another reason why you would be high risk. Carrying more than one fetus is going to make you high risk. Being greater than 18 makes you at high risk, believe it or not. That's kind of funny. And then advanced maternal age. So mothers who are older are definitely at high risk. So right when I had my, my second pregnancy, they considered me high risk even then because of my age, and I wasn't even that old. So it was crazy. Okay, so then this gets into a little bit about preterm labor and birth. All right, so what is preterm labor? So this is where you would have regular contractions of the uterus that result in changes in your cervix before 37 weeks of gestation. So typically, 37 weeks and beyond, you are considered term and you're okay. But this is before that 37 weeks, so you don't want to go into labor before then. So preterm birth is the leading cause of neonatal mortality, and it's most common reason for antenatal hospitalization. So we see a lot of that, unfortunately. All right, so when this talks about pathophysiology, under that section, they talked about 4 major factors that lead to preterm labor. Excuse me. One of those things is excessive uterine stretch. Another thing is decidual activation of, decidual activation and distension. The third thing was premature activation of your normal physiologic initiators of labor. And then the fourth thing was inflammation and infection in the decidua. All right, when it talks about risk factors of preterm labor and birth, now there's like 3 that are the most common, but there's other things that can kind of affect this as well. But the 3 most common ones would be prior preterm birth, multiple gestation, and uterine and cervical abnormalities. So, of course, things like some of risky behaviors or something like that could cause you to go into preterm labor. Spontaneous preterm labor and birth can result from several things too, like infection and inflammation. That could do it as well. Obviously, we don't want someone to go into labor too early. So viability of a fetus is about 25 weeks. So rarely do we try to deliver before then, because usually the baby doesn't make it. They don't do really well. So 25 weeks is kind of our cutoff right now. Years ago, it wasn't even that. It was, a lot later. So because we have so much technology and we've come so far with medicine, now we're able to do 25 weeks. All right, so other things I wanted to mention here. So if a woman goes into preterm labor, she's at risk for some things. So complications related to treatment with tocolytics. Can't say it, tocolytics. So she could get things like cardiac arrhythmias, pulmonary edema, and then also congestive heart failure. If you're saying to yourself, what the heck is a tocolytic? A tocolytic is going to be a medication that's used to suppress uterine contractions to try and prevent preterm labor. So there is a box in your book on page 155 that says common tocolytic agents, and it mentions all of them. So like, for example, there's a calcium channel blocker. There is non-steroidal anti-inflammatory drugs, believe it or not, that sometimes they'll give. So this would be indomethacin. There is beta-adrenergic receptor agonists. So this specifically would be your terbutaline. And then also they mention mag sulfate on here. That's another one that sometimes they'll give. So some of these can have some pretty serious adverse effects. So I just want you to make sure you take a look at that table there, because it tells you all about them in more specific, detail. Especially like that mag sulfate. I think that's a big one that you should know, and the terbutaline. All right, some other things that the chapter mentioned a little bit about was, if you are going to, have this person have labor early for some reason, like maybe you can't stop it and you have to do it, then you want to give corticosteroids so that you can try to help the lungs of the baby mature enough so that they're going to be able to have a better chance. So corticosteroids would be given between 24 and 34 weeks gestation. And you would only give these to the woman if you think that they're going to deliver within the next 7 days. The specific medication that we give is betamethasone. And usually it's like an IM shot, 12 milligrams every 24 hours for 2 doses. And unfortunately, because it is a steroid, it can make the mother's blood sugar go up. So that's something that you have to watch for. A couple other things to talk about with preterm labor. With these tocolytic drugs, you need to report to the provider if this person's blood pressure goes higher than 140/90, or if it's less than 90/50. You also need to report if their heart rate is greater than 120, and then also if their temperature is greater than 100.4. Now, there also is a little bit of risk to the newborn when they're born early, so they can have complications from prematurity. So we talked about a lot of that in some of the other chapters of what they might look like if they come out a little too early. So with assessment findings that you might see with someone who is in preterm labor, you could see a change in the type of vaginal discharge. So it could look watery, mucousy, or bloody. There could be an increase in the amount of discharge. This person could have pelvic or decreased abdominal pressure, constant or lower dull back pain, mild abdominal cramps with or without diarrhea, regular or frequent contractions or uterine tightening that's often painless, and then possible ruptured membranes. So those would be things that you might see if you were assessing them if they're going into preterm labor. Now, if someone does have a rupture of membranes, like say you're trying to keep them from going into premature labor and you give them all these tocolytic drugs, but then their water breaks, well, then that's kind of that's something that happens that you're going to be worried about then, because now you're worried that they're going to get infection because you have an opening to the environment. And so you should do immediate delivery if that's the case, if their membranes rupture. Now, there are people who, like, say it's like way too early for you to deliver. Sometimes physicians will, like maybe you have an incompetent cervix or something that it's just not, keeping the baby in there. So sometimes physicians will actually sew close the cervix if they think that would be beneficial to this person, try and keep the baby in longer. And then when it's time to deliver, they would, undo all of that, of course. Okay, so then the chapter gets into multiple gestation. Okay, so multiple gestation, of course, just means that you're having more than one baby. Now, in the chapter here, they talk about monozygotic and dizygotic twins. So monozygotic means that one zygote divides in the first week of gestation, and that's how you get the two babies. So these babies would be identical genetically and similar in appearance, and they always have the same gender. So that's monozygotic. Dizygotic means that there was actually fertilization of two eggs right at the beginning there. And so with this type of groups of twins, they may be the same or of differing genders. So you could see a male and a female maybe. So in the chapter, it was also saying that there's an increase in multiple gestations because there's more of a shift towards older maternal age now. And then we also have a lot of new technologies, like, there's increased use of assisted reproductive technologies. So, in vitro fertilization and all of these different things that we do. And sometimes that will result in multiples. So as far as risks go, for the woman, so she is going to be more at risk for hypertensive disorders and preeclampsia, gestational diabetes. She could be at risk for antepartum hemorrhage, anemia, cardiomyopathy, cesarean birth. There's like a huge list of things. All right, and then for the newborn is going to be, or the newborns, I guess, are going to be at increased risk of morbidity and mortality. They would be at increased risk for preterm delivery, low birth weight, increased risk for intrauterine growth restriction. And there's also something called twin-to-twin transfusion syndrome that you'd be worried about. What this is, it's where blood from one twin is transferred to the other twin. And so that twin would have too much blood circulating in their body, and it could cause circulatory overload and heart failure. And then the other twin would be severely anemic because all of their blood is in the other twin's body. So that's twin-to-twin transfusion. Okay, so with assessment, when you're assessing someone that has multiple babies, some of the things that you would see, of course, would be an increase in fundal height and size, increased cardiac output. If you were doing testing, you would see an increased HCG and alpha fetoprotein level. And, there's a lot more things as well. All right, so with antepartum management, we want to possibly do genetic testing, for anomalies. So obviously that's up to the parents on whether they want to do that or not. You want to watch for different problems like anemia, hypertension, intrauteral fetal demise, anything like that. So you're going to be, really monitoring the mother and babies well. Intrapartum management. So we're going to do continuous fetal monitoring of both babies during this time. And then for nursing actions, this is talking about stuff that we would do, throughout this person's pregnancy here. So one of the things that the chapter talked about was the woman may need a nutritional consult because she's at higher risk for iron, calcium, and magnesium deficiencies. She needs those things in increased levels to support the growth of multiple fetuses. And then, sometimes cesarean birth is often recommended for multiples. And then, of course, triplets and higher multiples are always going to be delivered by cesarean. So like for me, when I had my twins, they actually had me deliver in the operating room just to be on the safe side. So I really had a pretty uncomplicated pregnancy for the most part. And so when they checked, the babies were in a decent position to come out. They weren't breech or anything like that. So they had me deliver in the operating room because they were going to try vaginally to see if I could do that with both. And, the idea is you're in there just in case there's a problem, and then you could convert to a cesarean if that was the case, So sometimes they'll say, like, you'll be able to birth one of the babies just fine vaginally, and then maybe the other one there's an issue, so you have to, get them out cesarean. So that's why they had me in there. So, but yeah, so those are some of the things to think about with that. All right, hyperemesis gravidarum. So, wow, this is a horrible thing, and I'm so glad I did not ever have this. I hope none of you ever get this either. So, what this is it's vomiting during pregnancy that is so severe that it leads to dehydration, electrolyte imbalances, acid-base imbalances, starvation, ketosis, and weight loss. So it's like super extreme. With assessment, you're going to see things like vomiting that is prolonged, frequent, and severe, weight loss, ketosis, lightheadedness, dizziness, tachycardia, dry mucous membranes, poor skin turgor, decreased blood pressure, and just a general malaise. They just feel awful. So what we do with this for management. So the first line treatment of this is giving them vitamin B6 and doxylamine, something like that. And then also you would do IV hydration, dextrose and vitamins, and thiamine. You would give all of that stuff. So I remember I had a friend of mine who their wife had this during pregnancy. This was a friend of mine that I worked with, and his wife just was awful. She kept having to get admitted to the hospital to get treated for this because they couldn't get it under control. She finally ended up having to be on TPN. So they sent her home on it, and she had like a home pump that they had to take care of, and she had to do that like forever, it seemed like. So she was losing all this weight and had all these issues. It was horrible. So there's a number of different things that they can do for it. And so everyone's a teeny bit different with how they respond to stuff. So that's kind of, how that goes. But some of the things that you can do as a nurse to help would be, you know, just basic things like, mouth care and comfort measures, keeping bad smells away from them. Give them ginger ale because ginger kind of helps a little bit settling the stomach. And they also say foods, if you're going to have this person try to eat, you should do fluids before they eat, 30 minutes before, and then also follow fluids, with their solids 30 minutes after to minimize the effect of feeling like too overly full, like you have a super full stomach. And then they also mentioned, some people just don't have good luck at all from some of the treatment. So they say to maybe you as a nurse can suggest other things like complementary therapies, such as acupuncture. Sometimes that type of stuff will help them feel better. All right. Um, then this gets into diabetes a little bit. So they talk about pregestational and gestational. So pregestational is categorized as someone who already has diabetes. They either have type 1 or type 2 when they get pregnant. So they already have it, it's established. Gestational diabetes would be glucose intolerance that does not present prior to pregnancy. So first of all, let's just talk about the pregestational person. So if I'm someone who already has diabetes and I get pregnant, I'm at risk for things like DKA, hypertension and preeclampsia, preterm labor, spontaneous abortion, induction of labor, you name it. There's like a huge list of things. And then, the baby is also at risk for things. So congenital defects, growth disturbances, birth injury due to macrosomia, which I don't know if you guys understand what macrosomia is, but generally if you are pregnant with a baby and you have diabetes, your baby sometimes gets really big, and that's what they're talking about here with the macrosomia. So you could get a birth injury because as the baby's coming out, something could happen because they're just too big to come out that way. So basically, with diabetes then, self-management is super important. So this person, we would want them to check their sugars a ton throughout the day. So like 4 to 8 times a day, they say. You want them to also self-monitor for urine ketones when their blood sugar is greater than 200. And then to exercise 3 times a week, 20 minutes at least when they exercise. And then also review signs of maternal hypoglycemia with them. Make sure they understand what to do for that. Then with gestational diabetes, let's talk about that for a minute. So with that, basically your body thinks that you're diabetic. So it mimics someone who's type 2 diabetic, when you have gestational diabetes. So typically you usually find out that you have this between 24 and 28 weeks gestation when they do that sugar test with you. And like I had this with my twins, and for me, I was only like 2 points off on my sugar test, and they still were like, yes, you're gestational diabetic. This is what you need to do, So as far as risk factors for people who get this, sometimes there's no known risk factors. And like this is about 50% of all people with gestational diabetes. They don't have risk factors, but yet they get it anyway. Then other things would be maybe you've had big babies before, or you have a strong family history of this, or you're obese. Those would be some other things that would maybe put you more at risk. So basically with this, your placenta, when you're pregnant, your placenta is like putting out all of these hormones, and these hormones are antagonizing your your body. It's making your body think that you are type 2 diabetic. So the interesting thing is, the minute you have the baby and the placenta comes out, then that takes care of your issue. You're not having the problem anymore because the placenta is not there anymore to do that with the hormones. So it's all about those hormones that the placenta gives off. Okay, so risks for women when they have this, of course, preeclampsia, cesarean birth, hypoglycemia, DKA, anything like that. And then risks for the baby would be, intrauterine growth restriction, macrosomia, shoulder dystocia. There's a ton of things. So really, with both of these then, the goal is just to keep really good glycemic control throughout the rest of your pregnancy, because if you do, then you're going to have, a better outcome for both the mom and the baby. Okay, so who's at risk for gestational diabetes? It's going to be D, all of the above. Okay, so then this gets into a little bit about hypertension. So with hypertension, they consider hypertension anything with a systolic blood pressure 140 or greater and a diastolic blood pressure of 90 or greater. This is the most common complication of pregnancy, and it affects about 10% of all pregnant women. It's the second leading cause of maternal death and significant contributor to morbidity and mortality in babies. So on this slide, it talks about different types of hypertension in pregnancy. So we're going to kind of define each one of these so you can get a better picture of what each one means. So preeclampsia and eclampsia. So preeclampsia means that you have a multi-system hypertensive disease that's unique to pregnancy. So you have hypertension that's accompanied with proteinuria after 20 weeks gestation. So you have protein in your urine and hypertension. Eclampsia is the onset of convulsions or seizures. So you would hope you would, catch it before someone gets to that stage. All right, the next one they mention is chronic hypertension with superimposed preeclampsia. So this person also would get the same type of stuff. So, around 20 weeks gestation, they would get hypertension that's accompanied with proteinuria, but now they also get some other things along with it. So now they get increased liver enzymes, they get thrombocytopenia, they get headaches, pulmonary edema, and there's a couple other more that I didn't write down. There's a lot of things that are associated with this. So this one's a little bit more severe. Then there is also a gestational hypertension. So this is where the mom would get a high blood pressure for the first time after 20 weeks gestation. And they don't have any other signs or symptoms that are associated with preeclampsia. And then the chronic hypertension would just be someone who just already had it before they even got pregnant. All right. So we kind of already defined preeclampsia a little bit here. So let's talk about some of the other things that go with it here. So we said risk factors. Let's talk about that. So risk factors for getting this would be an age younger than 20 or older than 35, obesity, multiple gestation, family history of this, gestational diabetes, chronic hypertension, kidney disease, or lupus, nulliparity. Those would be some of the risk factors. All right, so if a woman gets this, some of the risks that she has that you'd be worried about if she had this she would be at risk for stroke or hemorrhage, pulmonary edema, congestive heart failure, abruptio placenta. And it also says in here that women with a history of preeclampsia have a 1.5 to 2 times higher risk of heart disease later in life. So some of your assessment findings, of course, you're going to have a high blood pressure like we talked about, the proteinuria, and then they're also going to look at some other things along with this. They're going to monitor your labs to, monitor your liver function and kidney function and things like that. So what we do for this, so they say women with early onset preeclampsia, before 34 weeks gestation, are going to need corticosteroids to facilitate fetal lung maturity. So once they're diagnosed with this, they should be monitored pretty closely after that. So, they want to see if maybe they're going to have to deliver this baby early or not. So the primary goal in preeclampsia is to control the woman's blood pressure and prevent seizure activity and cerebral hemorrhage. So some of the things that they do, of course they're going to give antihypertensive meds to control the blood pressure. Mag sulfate, a central nervous system depressant, has been proven to help reduce seizure activity without documentation of long-term adverse effects to the women and fetus. So, you might see that given to help with that. So typically for hypertensive disorders, usually they plan for an early delivery because that's usually better for the mother for her outcomes. All right, so that's kind of what that is. Let's go on. They do have a chart in the book that talks about some of the medications that they give for that, if you wanted to take a look at that. All right, also there's something called HELP syndrome. This stands for hemolysis, elevated liver enzymes, and low platelets. So it's used to designate the variant changes in lab values that can occur in a complication of severe preeclampsia. So basically, if you had severe preeclampsia, you could get this HELP syndrome. So the hemolysis is a result of red blood cell destruction as the cells travel through constricted blood vessels, because as you have a high blood pressure, your blood vessels constrict. Elevated liver enzymes result from decreased blood flow and damage to the liver. Low platelets result from platelets aggregating at the site of the damaged vascular endothelium, causing platelet consumption and thrombocytopenia. So things that would, like if you were doing labs, what would indicate this syndrome would be platelets less than 100,000. Your liver enzymes, you would see an elevated AST and an elevated ALT. The bilirubin would also be elevated, and the LDH would be elevated. So things you'd be worried about if they had this. The women, the risk to her would be renal failure, liver hematoma, abruptio placenta, and death. So, this is a huge deal. And then for the baby, premature birth or death. So what do we do for this? So the only definitive cure for HELP syndrome is immediate delivery. So resolution of the disease is generally in 48 hours postpartum. So typically you recover after that. So that's a huge deal. So remember that. All right, the next stuff starts to get into problems with the placenta. So placenta previa. So placenta previa is occurs when the placenta attaches to the lower uterine segment of the uterus, near or over the internal cervical instead of in the body or fundus of the uterus. So the placenta attaches in a crazy spot. in your book on page 181, there's a picture at the bottom showing these different placenta issues. And this would be A, placenta previa. So it's kind of over the opening on where the baby would come out. So the cause of this is unknown. So women with this will have an approximately 10-fold increased risk of antepartum vaginal bleeding. So they're going to be at really high risk of bleeding. Hemorrhage is especially likely to occur during the third trimester with development of lower uterine segment and when the uterine contractions dilate the cervix. So placenta previa is most often diagnosed before the onset of bleeding when the ultrasound is performed for other indications. So if you can catch it early, you can help with this. All right, so risks to the mother. So the big one is hemorrhage with hypovolemic shock. Other ones would be potential RH sensitization in RH negative women. And then other things would be septicemia, thrombophlebitis, and even maternal death. For the baby, risks would be blood loss, hypoxia, fetal anemia, disruption of uteroplacental blood flow. All right, so on here it says the classic presentation used to be painless vaginal bleeding in the third trimester. Sometimes the bleeding would be associated with abdominal pain, contractions, or both. So that's kind of what you would see. And then, so what they do for this, emergency medical management would be cesarean delivery. You know, that would be necessary because obviously the placenta is in your way. You can't get the baby out otherwise. So they said vaginal delivery can be attempted with a low-lying placenta if one can proceed with emergency cesarean birth if needed. So if you could convert to that, maybe you do that, but I don't know why you would want to even try. And then medical management after stabilization. So they say some of the things we would, focus on doing. We want to evaluate the color and the characteristics of the mother's bleeding afterwards. We want to assess their vital signs frequently. She can have a really big blood loss with this, so like a 40% maternal blood loss. So that's going to really affect her vital signs. So we're going to have to watch that really closely. We're going to monitor her urine output and her level of consciousness and all of that kind of stuff. So that's a huge thing to really watch for. So basically, placenta previa, the placenta's over the opening where the baby would come out. So it's towards the bottom of the uterus. And this means that your biggest concern is bleeding, and you would have to deliver with a cesarean, most likely. Okay, the next one is placental abruption. So what this means is so you have like a hematoma that forms leading to destruction of the placenta next to it. So you have like bleeding that's inside where the baby's at, inside the sac that the baby's in. So there's several risk factors that are known for this. You can have like different grades to this. So when they say placental abruption, they can say grade 1, grade 2, grade 3. Grade 1 would be a mild one, grade 2 would be moderate, and grade 3 would be severe. Bleeding with this is almost always maternal. So this is a dangerous condition for the woman and the fetus. So with this, some of the risk factors, for getting this would be previous abruptions. So in your other pregnancies, maybe you've had it before. Hypertensive disorder, multiple gestation, abdominal trauma, cocaine or methamphetamine use. And so risks for the mother would be, hemorrhage, of course, maternal death, risk for the fetus, low birth weight, stillbirth, perinatal death. So things that you would see associated with this with assessment would be things like vaginal bleeding, hypovolemic shock, severe abdominal pain, uterine contractions, nausea, vomiting, that kind of thing. And then the fetus, you would see stuff like tachycardia. Some of the fetal heart rate patterns might change with it as well. So what we do with this, so if the abruption results in unstable or deteriorating maternal or fetal status, you're going to just do a cesarean regardless. Medical management, of course, if you knew about this ahead of time, you would give corticosteroids to help with the baby's lungs. And then you're just going to watch really closely after they give birth. And then the last one here is placenta accreta. So this is a term to describe the clinical condition when part of the placenta or the entire placenta invades and is inseparable from the uterine wall. So if you looked at this one, what you would do for this, the timing of delivery in cases of this would be individualized. So the decision should be made jointly with the patient, obstetrician, and neonatologist. Generally, the recommendations for management of a suspected placenta accreta would be, a cesarean, and then probably a hysterectomy along with it, it says. So, for this person then, that would be a big thing, if they had to get a hysterectomy, they wouldn't be able to have any more kids after that. So it's a huge deal. All right. We're kind of running out of time here. Let me see if I can get more into some of these. So I told you about these. All right. All right, do you guys know what an ectopic pregnancy is? Have you heard of that before?
Isn't that like one of the pregnancies outside of the uterus?
Yes.
Isn't that in the fallopian tubes?
Yeah. So you have this fertilized egg that grows outside of the uterus. So that can be, a big thing that you might see as well in someone who is pregnant. So with this, if that pregnancy grows, it can cause that fallopian tube to rupture or burst. So, you need to have surgery when you find this out. So that's a big deal. And, some of the risks for the mom would be like bleeding, and you could have fertility issues after that as well. Sometimes like assessment findings would be, you get this pelvic or abdominal pain that's with it, that sometimes it's sudden and sharp, light or heavy bleeding. All right, so basically, the chapter goes through a bunch of different types of disorders. So I really want you guys to make sure you pay attention to quite a bit of this, because there's a lot of important stuff in this chapter. I'm going to try and hurry up and get through the rest of this real quick. So on this slide, it's talking about STIs, so sexually transmitted infections. This is always a big concern during pregnancy, that maybe something gets passed to the baby as it goes through the canal and it is born. So, STIs can cause a lot of trouble. So you just want to make sure that you have a good assessment with your patient to make sure you know if they actually have this or not. All right, a fertilized egg that implants outside the uterus is an ectopic pregnancy. All right, so in summary, pre-gestational and gestational complications pose a lot of risks to the mother and the fetus. So high-risk pregnancies require astute assessment and specialized care to optimize maternal and fetal outcomes. So again, some of the things that you really tend to see a lot on some of these tests would be things about some of those placental problems, so make sure you really know those. They're always going to ask things about preeclampsia, so that's really huge. Gestational diabetes is another big one. And then the preterm labor stuff is really important. So make sure you're really focusing in, good on those things. All right, so I'm going to get off here with you guys now, so we have a little bit of time before our next class. We'll come back on here at 12:30 for community. Do you guys have questions about anything? Okay, so come back on here at 12:30. If you have questions about your remediation or something, just email me and I can tell you more.